For decades, the story of type 2 diabetes in the United States was the story of too late. It was traditionally a disease of the elderly, a slow, progressive decline that we tried to manage, but was rarely ever stopped. But something shifted. Type 2 diabetes isn't just an adult onset disease anymore. In the last 20 years, cases in youth have nearly doubled. For a long time, public health officials were fighting a forest fire with a garden hose. Until now. These are GLP-1 receptor agonists. You likely know them by their brand names, Ozempic, Wegovy, or Mounjaro. By 2026, they aren't just weight loss shots anymore. They have become the most aggressive tool we've ever had to rewrite the future of metabolic health. But as we begin prescribing these to teenagers at record rates, we have to ask a difficult question. Are we curing a disease, or are we just masking a broken system? To understand why this is such a massive shift for young people, you have to understand the Incretin effect. When you eat, your gut releases a natural hormone called GLP-1. It performs two vital jobs. It tells your pancreas to release insulin, and it tells your brain you're full. In people with type 2 diabetes, however, this signaling system is essentially muted. These new drugs aren't just giving you more of that hormone, they are super mimics. They stay in the body longer and they shout much louder than the natural version. For a 16-year-old with type 2 diabetes, this is a miracle. Standard treatments like metformin often fail in children significantly faster than they do in adults. But recent data from 2025 and 2026 shows that GLP-1s can essentially reset a teenager's metabolic clock, bringing A1C levels back into a normal range in a way we've never seen before. However, this isn't a simple happily ever after. We are now prescribing a forever drug to people whose bodies are still in the middle of developing. The evidence is still catching up to the trend. While these drugs protect the heart and the liver, new research presented this year suggests potential long-term risks to bone density, specifically regarding osteoporosis and metabolic bone health. For an adult, that might be an acceptable trade-off. For a 14-year-old in their peak bone-building years, we simply don't know the long-term consequences yet. Then there is the issue of the equity wall. Even though manufacturing shortages have largely stabilized and new programs like the 2026 Balance Initiative have capped some costs, many Medicaid programs, which cover the very children most at risk for type 2 diabetes, still don't consistently cover these medications for obesity or early-stage insulin resistance. Why are we even in this position? Because our modern environment is obesogenic. We have designed a world where the cheapest, most accessible food is the most metabolically damaging. We are using a high-tech biological fix to solve a low-tech environmental problem. Recent studies have found that these drugs work best when paired with healthy lifestyle changes. But healthy habits are a luxury when you live in a food desert or a neighborhood without safe places to exercise. So, what is the takeaway? GLP-1s are a triumph of science. For the millions of young people facing a lifetime of diabetes complications, such as kidney failure, vision loss, and heart disease, these shots are a literal lifeline. But they are also a mirror. They show us that we would rather spend billions on a weekly injection than fix the way we produce food or design our communities. We have finally found the off switch for hunger. Now we have to decide if we are comfortable with a world where the only way to stay healthy is to stay medicated.